guys, I'm going to make a start, if that's all right with you. So just to give you a little bit of an overview, at the moment, I am basically talking about thresholds of viability. And what we're going to do is we're going to run a little bit of an interactive workshop today where I'm going to give you a little bit of a revision of what we've done so far. But after that, we're going to talk about the different definitions of viability. We're going to come to an agreement about what we think is the medical definition of viability, especially in a high income versus, I would say, a low income developing country. And then I'm going to give you an approach to thresholds of viability, but mainly speaking of a high income approach today. That will be followed by questions. So we're going to go through a few cases that you're going to talk to me about with regards to your approach. Is that okay? Fantastic. So to start off, I'm going to give you a little bit of an overview of what we've done so far. So we're kind of in the situation where we're coming to the end of week 1. We've covered perinatal epidemiology, and we're actually have discussed limits of viability from the perspective of a developing country. We're now going to address that from a developed high-income country perspective. But what we're going to do is talk about what the parental understanding and the parental perspectives might be when we're talking to them about babies, say, between 22 and 24 weeks in Western or high-income countries, versus how we might be approaching parents who actually deliver at limits of viability in low-income countries in their setup. Once we do that, we would have completed week 1 of the enrollment. I'm hoping that you guys have done the MCQ. Because from our perspective, that gives us a little bit of perspective of what we've covered in week 1, and I'll be able to return your scores to you. So going forwards, I think what I'm going to do is I'm just going to revise a little bit what viability means as a concept. And I think the most important aspect of this is there is a difference between medical viability as we define it, a difference between legal viability as the courts might define it, and in particular from our perspective, I think how the parents might understand in particular the limits of viability at the lower end of the threshold for babies who are born, say, at the lower limits of viability in their setup has huge meaning. And this comes in mainly because parents often have to make decisions, shared care decisions, in keeping with us, where we look at counseling them with regards to resuscitation. Now, obviously, they have a say in this, and some parents would want us to resuscitate their babies, and we might be happy to do that. But in other circumstances, we might actually disagree. And the question from our perspective is how you then come to a consensus about what the right thing to do is in that situation for the baby, for the parents, and for the entire multi-professional team as a whole. So by definition, if I just look at definition, viability of a fetus means having reached a stage of development so as to be capable of living under normal conditions outside the uterus. Now, defining this is very difficult. And the reason for this is resources and setups differ from country to country. And what might be provided in a country like the UK or Belgium, say, for example, we might not be able to provide in a country like Nigeria or India because of the absence of resources, appropriate medical technology to keep those babies alive. But more importantly, it might be that there are other constraining factors like the economic situation of the family, as well as, I would say, the ability of hospital care to sustain babies because of rationing of what I would say care, where they are prioritized more towards looking after babies or children who have illnesses similar to malnutrition and diarrhea in that particular setup. One way of looking at it, which might satisfy definitions everywhere, is trying to define non-viability. And if you look at how it's defined in the McGraw-Hill dictionary, non-viability talks about a fetus as being expelled, which may have signs of life, but would not be able to survive to the point of being able to sustain its life independently. It would need the support of the best available medical care. Now, this definition again would help us define viability in the context of a lot of countries, because if you've got the ability to provide CPAP but not intubate and provide surfactant in a particular setup. It might actually mean that your ability to resuscitate is limited to babies over a certain gestation, say 28 weeks, for example. And if you look at a country like India, the definition of viability as per law is actually 28 weeks in India. Now, what we also know is that there is a little bit of an overlap between abortion laws in various countries and how we define limits of viability. And in particular, what we've got to be able to differentiate is when the condition of the baby becomes appropriate for it to be considered as important from a health perspective as that of the mother. Now, that in some states means, especially in the United States, that actually babies from 19 weeks of gestation onwards are believed to have the same right to life as does the mother, as long as the health is not compromised. And that, for the medical legal definition, would mean that that baby at 19 weeks is actually viable. But if you look at a general legal definition provided by the United States in law, this is the law as quoted in 2019, and it talks about a non-viable fetus as a fetus that's not capable of living or developing, uh, cannot possibly survive to the point of sustaining life independently, even with support of the best available medical therapy. And in a way, what they're trying to define is what the legal status of non-viability is in this particular definition. So what I can see is I've probably left you very confused. So what I'm going to do is summarize what exactly I mean. Now, what we've got to look at is how we manage babies at extremes of viability or threshold of viability or limits of viability. So different terminology that's actually given to the concept of viability at the lower end of the spectrum. And what we can clearly see is there are different definitions. There's a definition that we have, which is as defined by medical professions. There's clearly medical legal definitions which vary from country to country. But I can't emphasize enough that this is not just limited to medical professionals or healthcare professionals in general. It's not limited to courts. Actually, what we've got is we've got parents and we've got lay public, both of whom have a different concept of what they might be thinking is how we should be sustaining life for the smallest babies in particular. And that might fit into different perspectives. So parents might have religious reasons for wanting resuscitation of their babies at the lower end of the spectrum. Uh, some I would say lay members of the public have a philosophical approach to how they might actually define the rights of a baby at the lower end of the spectrum. And then we have scientists who are clearly doing research, which actually trying at this particular point to define when the fetus actually has a consciousness, or more appropriately, when the fetus is actually able to perceive pain or sensory stimuli. And this is obviously a very abstract concept. The reason being, is it enough for us to say that a fetus is alive in the mother's womb and has achieved a viable status merely because it can actually perceive sensory stimuli like pain? Uh, I think the most important other aspect to it is some of the scientists are actually arguing that it's not just the perception. Actually, it's how the fetus that responds to such a stimulus that should actually tell us whether the fetus is actually capable of actually, doing anything in response to that sensory stimulus. And that would actually qualify as the fetus having consciousness. Some people try to link that with personhood. Now, in our minds, as medical health professionals, or say clinicians or neonatologists or neonatal staff, we would like to think that we're right with regards to how we manage babies because of the way we define medical viability and the limits of viability. But actually, how parents, the lay public, might actually understand this might be completely different. And in my mind, if there are differences in how they understand it versus how we define it, then there are risks that actually we might have disagreements when we're actually counseling parents. And this forms the basis of an approach that I'm actually going to discuss with you today that you can adopt. I think what is very clear from our perspective is that you do have to have some medical definition, that there are limits of intensive care. And, from our perspective, what we can't do is resuscitate every baby. We can't, from our perspective, start thinking that we are doing a good job by actually resuscitating babies under a certain threshold. And in medical parlance, that is defined in different ways, or given different terminologies is the better word to use it. So some people would talk about that as the threshold or limit of viability. Some people call that periviability. But what they usually mean is that below that limit, even with active intervention, it is very unlikely that with existing medical technology, resources, and infrastructure, we're going to be able to sustain those babies. I think if you look at how this is defined in the literature, certainly in most Western countries, and in literature that I will show you, we would probably say that most infants above 26 weeks of gestation have a very high likelihood of survival. Certainly in my hospital in Southampton, survival at 26 weeks is over 90%. To give you an idea, survival at 25 weeks is about 83%. And these are 3-year rolling averages. Uh, Again, what we'd probably agree is that there are virtually no survivors below 22 weeks in most, I would say, modern Western resourced intensive care setups, which actually look after neonates. So what you will find when you actually look at the literature is case reports, some of which I've actually attached to the website, which look at survivors for babies who are 21 plus 5 or 21 plus 6 weeks of gestation. I think the key thing that I'm going to emphasize is even though we've defined these limits and then consider babies, say from 22 weeks to 25 plus 6 weeks as being within the threshold of viability, parental expectations are going up all the time. And, I've clearly been in situations where uh, parents have wanted me to resuscitate babies as small and as young as 22 weeks of gestation at a time when we weren't resuscitating them. And I've also been in situations where I would say parents are not keen for us to resuscitate babies at 24 or 25 weeks of gestation because of their anxieties around the risk of disability, but other factors that are very important to their ability to be able to sustain this child should it actually survive through the neonatal unit. So if we take these parental expectations in mind, what I'd like to do is just give you a little statistic here. And if you look at the statistic, what you'll see is that there's no doubt that survival has actually improved over an extended period of time. So while in the 1970s, babies under 800 grams did not survive, and generally babies, I would say under 28 weeks did not survive, even in high-resourced intensive care setups in the West. What we've seen is that coming from the 1960s to about 210, the gestational age at which we achieve 50% survival has decreased from 30 to 31 weeks to about 23 to 24 weeks. I would say that's even higher. So, just to quote my setup to say that a 3-year rolling average at 23 weeks is about 80% survival. At, I would say 24 weeks of gestation, you're coming to a region of about 80% survival. And at 25 weeks of gestation to 26 weeks, it becomes slightly higher. Uh, if you look at babies who were resuscitating at 22 weeks, we've only just started in Southampton. So we've only resuscitated 2 babies. And of that, only 1 baby has so far survived. Our numbers are small. But clearly, if you look at other Western countries or countries like Japan, where they resuscitate 22 weeks and have been doing so for an extended period of time, survival is higher. So in Japan, the quoted survival for babies born at 22 weeks is about 30%. Uh, Survival in our setup, I would say, probably is about in the range of about 11 to 20% in the UK, based on very, very small numbers. So what we can see is we're challenging the limits of viability, as time has gone by, and the lower limit of this has actually gone down. Now, a key question from our perspective is we all know that gestation is not an accurate marker of how we should be defining viability. In that, even with most established methods that we use with regards to trying to diagnose the accuracy of gestation, ultrasound is out even if you have a dating scan by about plus minus 5 days up to a week. So, you might be resuscitating a baby at, say, 22 weeks, and it might actually be 23 weeks. On the other hand, you might be resuscitating a baby at 25 weeks, and it might actually be a baby that's 24 weeks of gestation. So there are a number of factors that we have to consider in addition to gestation. Weight used to be one of those factors, but with those factors, one of the things that's absolutely essential is that we're thinking about parents and what they want. The shared care decision-making approach has actually been emphasized a lot and has probably become the norm in terms of how we approach discussions and decision-making when we counsel parents at this particular point of time. I would actually like to take you a step ahead when we talk about how we counsel parents to kind of say that it is shared care decision making, but actually you have to think about how you make a judgment of A, what the parents want, whether B, they're capable of making that decision. C, we mustn't actually be in a situation where we bring our personal kind of feelings or our personal values into discussions like that. And I think, that's where I would say that there's a huge variation in practice, which you can see from the literature that we've garnered in the chapter. Now, if you look at me talking about this aspect of thresholds of viability, it is because what we know is there's a gray zone. What is a gray zone? So, a gray zone basically means that because of uncertainties with regards to gestation, but also because we might have overlaps between babies when we actually have discussions with the parents, uh, we would consider a spectrum of babies where the parents have a choice. And that choice might mean that they don't want us to resuscitate their baby. What is very interesting is that a study published in 2018, again, which is available on the website, shows varying gray zones even amongst highly developed, I would say, high income countries in Europe. So the gray zone, as defined in Sweden in 2018, was 22 to 23 weeks. On the other hand, if you went to the UK, before the new BAPM guidance was actually brought out in 2020, our gray zone was actually about 23 weeks. And if you went to the Netherlands, actually, it was about 24 to 25 weeks. A country that I would genuinely like to highlight is Denmark, where they have had, I would say, a very conservative approach to resuscitation at extremes of viability. I think, from our perspective, if you look at the culture and what society has accepted there for quite a long period of time, even up till 2018, when Dr. Gorm Gleason published his work in uh, a journal, Pediatrics, it was quite acceptable for comfort care to be offered to babies at 24 weeks if the parents did not want resuscitation. On the other hand, if you go to, I would say, less developed countries or developing countries like India and Nigeria, the limits of viability, as defined legally, are much higher. They're 28 weeks of gestation, and that creates a huge problem. What are we supposed to do for babies that are being born at between 24 and 28 weeks of gestation, who we would normally resuscitate in a high resource setup with intensive care facilities, but who are legally, by law, not defined to be viable? And a major problem there is the accuracy of how we record live births. So if a baby was to deliver in a public health system, say in India, uh, the rationalization of resources to manage diarrhea and malnutrition might mean that actually ventilation is only offered to certain babies above a gestation at which they normally survive in that setup. That might be 28 weeks for the public healthcare setup. But if you go to a resourced private hospital, actually, they would be perfectly capable of resuscitating babies over 23 weeks of gestation. The question then is, can the parents actually sustain that? And we looked at this quite closely in the last talk that was provided by Dr. Martin Zasso from Nigeria. I think what I want to do at this particular point is give you a little bit of a flavor of the medico-legal aspects here. And in particular, in developing countries, this is a major problem in that parents may look at and want resuscitation of their extremely preterm babies by making judgments of what's available in other countries, by making judgments of what is there in, I would say, the media, but without the knowledge that actually public healthcare setups might not be in a position to be able to resource fund or have the available technology to actually support them. That would then necessitate that they are actually moved to private hospitals where the cost of care they might not be able to afford. And this is quite a difficult area. So, to give you an idea, before 2018, there were no legal definitions in India for how you defined an extremely preterm baby, and babies under 28 weeks were considered non-viable. Now, there was a case which set quite a significant legal precedent in New Delhi in India, where twin deliveries at 23 weeks of gestation uh, were delivered in a private hospital, which attempted resuscitation, but felt that the babies were too immature for them to be able to sustain, and decided in the baby's interests that resuscitation was not appropriate. The babies, obviously, from their perspective, were then taken by the parents to a different hospital where the babies were resuscitated, but actually eventually died because of the difficulty with them being so preterm. And this led to the parents actually going to uh, the police and complaining that their babies had not been taken care of and died, and actually accusing the health professionals of actually having killed their babies in the first hospital. So it became very important from that perspective to then define, well, what are the lower limits of viability? And in India at the moment, this has been set at about 24 weeks of gestation by the Indian Medical Association, with the knowledge that actually, even in resource intense setups, resuscitating babies under that may result in a huge amount of burden to the parents, but also risks babies going through intensive care in a situation where they might not survive. Now, laws like this have been created in countries like the States long back, as early as the 1970s. And I think what I'd say is that in developing countries in particular, I think there's got to be work that's done simultaneously with lawmakers as well as with learned societies to try and agree how we would go forward resuscitating babies uh, below a certain gestation, with the ability to be able to manage situations where, say, parents are delivering in extremely low resource settings. To give you a slightly different flavor from the legal definition is a concept which has been referred to as personhood, and we've discussed this, but a lot of work has been done on this topic by Professor Hugo Langenkrantz, whose talk is available on the website. And clearly, what he, as a scientist, ethicist, and neonatologist, has tried to establish is when the baby actually becomes a person in utero, uh, whether at that point the baby should have rights, and whether those rights should actually give it a legal status over the mother's health. Now, I'm not going to deal with the latter aspects of that because I would say that's well beyond the approach that we're going to discuss today. But I think what I'd say is that if you look at works and studies, both of which are actually available on the website, there has been there have been studies which have tried to look at how the fetus processes sensory input. So work done by Penna, Giuseppe Bonacori, and Hugo Lagenkrantz. And what they've been able to determine is that actually, while you get functional thalamocortical connections for advanced pain perception at about 29 to 30 weeks of gestation, these sensory receptors start appearing as early as 23 to 24 weeks in the fetal brain. Now, the question from our perspective is, can you use the response that the fetus has at that particular gestation, or how it might react to pain, as a marker of saying that the baby is actually viable? And I'm not sure that we have the strength in the recommendations nor the evidence to be as categorical as saying that a particular cutoff gestation establishes viability based on functional neurological maturation of the fetus. My gut feeling is, having read the literature and read the work by Giuseppe Bonacori and Hugo Lagerkrantz, this is more a continuum. And we all know that nerves will not migrate and be in a particular place or develop on a particular day or cutoff gestation. This is more a continuum, or that takes place over, I would say, a period of days, weeks. So just the presence of, I would say, a sensory response to pain, in my opinion, at this particular point, can't be interpreted as medical viability for us to be able to make judgments about, I would say, the health of the fetus versus that of the mother. Clearly, I've got an opinion. I would strongly recommend that you read these articles, and be interesting to see what you think. The last bit of viability that I would like to address before we look at an approach is religious viability. And I can't emphasize this enough. And the reason for that is, we all know that the environment, not just in different countries, but if you just come to a country like the UK, we have parents from all environments, and they have beliefs, values. Some of these beliefs are governed by religion, and in particular, those beliefs in their mind gives their fetus or their unborn baby a right to life. The question from their perspective is, when does this right, from a religious perspective, become absolute? And I mean, if you look at religions like, I would say, Roman Catholicism and Hinduism, you're kind of in a situation where actually they believe that conception itself gives the fetus a right to life. On the other hand, if you look at the Talmud, it's clear that for the first 40 days approximately, or a certain period of time, that you know the fetus is not a person. So actually, the greater part of the fetus at that point is actually merged with the womb, and the fetus has not quite achieved conception. If you look at Islam in particular, they talk about a duration of between 40 and 120 days before ensoulment of the fetus takes place. I think the reason for wanting to bring this up is we might be in a situation where actually we're talking to parents who have a particular religious background or belief, and their belief in their baby's right to life in those circumstances is extremely important. And I must emphasize, it's important that we understand those beliefs, that we acknowledge them, and that we make every effort to try and understand why they think that way. But more importantly, I think from our perspective, is it's acknowledging their culture, their background, because this is important to them. And in particular, I would say that for some parents, resuscitation under 22 weeks or under 23 weeks of gestation, religion might be a very important driving factor, something that you might have to talk about, where your view of what is in the best interests of that baby for that pregnancy conflicts with the religious beliefs of the parents. Now, I think if you adopt a very strong position based on the doctor is always right, and that we've defined medical viability, the risk in that situation is actually conflict. And I would say that my experience of managing situations like that, and I'm going to say that, I've only done this for about 12 years. So, I would say it's really important that we are acknowledging, we're trying to make an understanding of the parental beliefs, and we're trying to address them alongside trying to bring them on board. I call it shepherding parents through what we think might be right for them as a family as well as the baby. So I've given you a little bit of an overview of and a revision of what we've discussed in the first three lectures. So what we've done is we've tried to define viability. We've talked about the limits of viability as we define them as medical professionals. But what we've also talked about is why those limits of viability might vary between a developed and a developing country. We've spoken about parental perspectives and the importance of the fact that parents bring their values and religion into it and might have a completely different concept of what they think is important about their baby. But there's a little bit of homework that I'd like you to do before we move on. And this is the homework that we're going to do over this week. So my question to you, and I would like you to go back to your setup. I'm not talking about definitions in the UK or the States. So we have about 29 participants in this course at this point of time, from 17 different countries. And what we're going to try and elucidate is, in our setup based on law and recommendations around management at limits of viability, does the fetus have rights? If so, when and how do we define them? And at any stage in your setup or in your country, based on law, does the fetus have rights that ever outweigh maternal health? So I'm really keen for you to do that. And what we will be doing is, when we send out the MCQ, there will be some interesting cases for you to have a look at and make decisions on again. I'd be very keen to see how you make decisions in those situations.